Bismillahirrahmanirrahim. I am Dr. Afrinesh Amanat and today we will discuss sudden cardiac death and rheumatic fever. This pathway explains how sudden cardiac death can occur. The majority of the cases occur due to myocardial ischemia produced by coronary artery disease. If it is of prolonged duration, it can lead to chronic ischemic heart disease, CCF, and ultimately death. The other change which can occur is acute plaque change, which can also lead to myocardial ischemia and MI with all the sequelae as produced in myocardial ischemia. Now, chronic ischemic heart disease is also known as ischemic cardiomyopathy. It occurs secondary to ischemic myocardial damage. The cause is either a previous myocardial infarction when the compensatory mechanisms like hypertrophy of residual myocardium fails, and severe coronary artery disease causing diffuse myocardial dysfunction is the major cause. Arrhythmias can occur due to ischemic or structural changes, and the main cause is mutation in the ion channels that cause aberrant repolarization or depolarization. Um, the sudden cardiac death most frequently occurs due to coronary artery disease leading to ischemia, and less often it occurs due to acute plaque rupture with thrombosis that induces fatal arrhythmia. Now we will briefly discuss hypertensive heart disease. It can affect either the left ventricle or the right ventricle. When it affects the right side of the heart, it is known as cor pulmonale. When there is systemic hypertension, it produces concentric left ventricular hypertrophy, and eventually elevated pressure overload can cause ventricular failure with dilation. When there is pulmonary hypertension, it leads to cor pulmonale, and the main cause is primary lung parenchymal or vascular disease. In this case, hypertrophy of right side of the heart is characteristic, but dilation can also be seen when the failure supervenes. In the figure A shows you the cross section of the heart, and here you can appreciate marked concentric thickening of the left ventricular wall, reduction in the size of the lumen. In the arrow shows you a pacemaker that has been inserted in the right side of the heart, and this steric sign shows you dilation of the left atrium. In the figure B, you can appreciate the right ventricle of the heart is markedly dilated and it has undergone hypertrophy with thickening of the free wall. Valvular heart disease. The valves can be affected by either occlusion, stenosis, or by regurgitation. The acquired aortic or mitral valve stenosis is responsible for 2/3 of all the valve diseases. And the major cause of stenosis is valve calcification. However, myxomatous degeneration can also occur. Infective endocarditis and non-bacterial thrombotic endocarditis. Infective endocarditis, as the name indicates, it is caused by some infective agent. It rapidly destroys the normal valves, or it can be indolent, or it can also cause minimal destruction of the previously abnormal valves. And in non-bacterial thrombotic endocarditis, as the name indicates, the main cause is some hypercoagulable state, and embolization is important complication. Now, what is rheumatic heart disease? This topic is very important because it is frequently asked in short essay questions, and you can also be given one or two multiple choice questions from this topic. Now, its definition comprises of two parts. Please remember, it is multi-system disease, and it is acute immunologically mediated multi-system inflammatory disease. And the second part comprises that it occurs after group A beta hemolytic streptococcal infection of the pharynx. This is also important to remember. but occasionally infection at the other site can also produce rheumatic heart disease, that is the skin. The affected person is mostly a child, and rheumatic heart disease is cardiac manifestation of rheumatic fever. Most of the clinical features are produced due to valvular inflammation and scarring. You are mostly given a scenario that a 5 or 10-year-old child develops streptococcal sore throat, and after 2 weeks he complains of joint pains and develops skin nodules and some nervous disorders. Then in this scenario you should think of rheumatic fever. There is deforming fibrotic mitral stenosis. Rheumatic heart disease is essentially the only cause of acquired mitral stenosis. Before proceeding further, I will tell you about the parts of mitral valve. Mitral valve has an anterior leaflet and a posterior leaflet, and they are joined by commissures. Posterolateral commissure. Commissure means fusion caused by some joint, and it is connected to the pupillary muscle through chordae tendineae. Now, what is the pathogenesis of acute rheumatic fever? Basically, it is a hypersensitivity reaction which occurs due to the antibodies directed against group A streptococcal molecules, and these antibodies cross react with the myocardial antigens. The basically the M protein of streptococcus produces antibodies, and these antibodies cross react with the protein in the myocardium and cardiac valves. The injury is produced through activation of the complement and Fc receptor bearing cells. CD4 positive T cells, they recognize the streptococcal peptides that cross react with host antigens and produce cytokine mediated inflammatory response. Now, this production of inflammatory response takes time, and this explains the time period of 2 to 3 weeks between the onset of infection and development of symptoms. Only a small minority of infected patients develop rheumatic fever, estimated to be 3%. This is due to the reason that genetic susceptibility is most likely the reason of producing symptoms in these patients. Morphology: acute rheumatic fever is characterized by inflammatory foci within variety of tissues. The main lesion is known as Askov body, and these are pathognomic of rheumatic fever. What are these Askov bodies? These are collection of mononuclear cells. And what are mononuclear cells? Lymphocytes, primarily T cells, plasma cells, and macrophages. Now, the macrophages which are present in Askov bodies are known as Initsko cells, and they may be associated with zone of fibrinoid necrosis. What are these Initsko cells? They have abundant cytoplasm, and within their nuclei the chromatin is condensed into wavy ribbon form. The other name given is also known as caterpillar cells. Here you can see the gross picture of the mitral valve. The arrows point toward the vegetations, and on the left side you can appreciate fusioning of the chordae tendineae. Thickening and fusion of the chordae tendineae. In the figure B, it shows you the microscopic picture, and the arrows point toward the Initsko cells. Here you can appreciate the chromatin has been condensed in the form of wavy ribbon. There is central zone of necrosis surrounded by the mononuclear infiltrate, and this is known as the Askov body. In the figure C and D, there is mitral stenosis with diffuse fibrous thickening and distortion of the valve leaflet. This is basically seen in chronic rheumatic fever. In the figure D, you can appreciate neovascularization, and in E shows you the surgically removed specimen of stenotic aortic valve. Ascuff bodies can be found in any of the three layers of heart, in the pericardium, myocardium, or endocardium, including the valves. Now, the pericardium, the change which occurs in the pericardium is fibrinous exudate formation. Involvement of the myocardium is known as myocarditis, and it takes the form of scattered Ascuff bodies within the interstitial connective tissue. Valve lesions can result in fibrinoid necrosis and fibrin deposition along the lines of closure. If the lesions are produced in subendocardium, small irregular thickenings are produced, and these are known as McCallum plaques. And this change is mostly seen in the left atrium. Chronic rheumatic heart fever, rheumatic heart disease. It is characterized by organization and scarring, organization of acute inflammation plus associated scarring. And here the Ascuff bodies are replaced by the fibrous scar. Clinically, the mitral valves exhibit leaflet thickening, commissural fusion, and shortening and thickening and fusion of chordae tendineae. This same line is repeatedly asked in the multiple choice question and even given in the short essay question. Now, the fibrous bridging across the valvular commissures and calcification creates fish hole, fish mouth, or buttonhole deformity, as shown in this figure. The valves, they are fused in a way that they resemble the mouth of a fish. And on microscopy, you will appreciate neovascularization and diffuse fibrosis that obliterates the normal leaflet architecture. Now, the mitral valve is involved in 70% of the cases, and combined mitral and aortic valves are seen in 25% of the cases. And please remember, the tricuspid valve is less frequently involved, as well as the pulmonic valve. Due to mitral stenosis, the left atrium dilates due to the pressure overload, and the combination of dilation and fibrillation produces a fertile substrate for thrombosis. And in long-standing cases, passive venous congestion develops, which can lead to pulmonary vascular and parenchymal changes, and this can lead to right-sided hypertrophy and failure as well. Now, what are the clinical features? Most commonly, children are affected, and in 20% of the cases when the attack occurs in the adults, the arthritis is the presenting feature, which is the predominant one. Symptoms can occur in all age groups, and they begin 2 to 3 weeks after the streptococcal infection. The symptoms are fever, migratory polyarthritis. Migratory means one large joint is affected after another. It remains swollen and painful for a period of days, followed by spontaneous resolution with no residual disability. By the time the symptoms develop, the cultures become negative. However, serum titers of antibodies against streptococcal antigen are elevated, streptolysin O or DNase. The clinical signs of carditis include pericardial friction rubs and arrhythmias, and myocarditis may be sufficient to cause cardiac dilation, functional mitral insufficiency, and congestive heart failure. And less than 1% of the patients die of acute rheumatic fever. Now, Jones criteria is important because it is asked in Viva as well as in short essay question. Jones criteria is used for the diagnosis of rheumatic heart failure, and please remember, it incorporates there is preceding group as streptococcal pharyngitis plus 2 major criteria or 1 major and 2 minor criteria. Now, what are the major criteria? Major criteria are migratory polyarthritis of large joints, pancarditis, skin changes like subcutaneous nodules and erythema marginatum, and nervous CNS changes like sydenham chorea. It is a neurological disorder with involuntarily purposeless rapid movements. Minor criteria include fever, arthralgias, high acute phase reactants, high ESR, prolonged PR interval on the ECG. Jones criteria. J, you can remember this mnemonic: J, joints, polyarthritis; carditis, pancarditis; and for nodules, E for erythema marginatum; S for sydenham chorea. Now you will be given the assignment. You have to write this along with the roll number to mark you present. Name the changes produced in the mitral valve in acute and chronic rheumatic fever. Thank you class for listening.